Hi, everyone. My name is Stacy Cusack. I'm an occupational therapist at the Children's Hospital of Philadelphia. I've been an OT at CHOP for about 10 years now, and I've been a part of our LCE clinic since about 2015. I also help with the research that we conduct in our Leukodystrophy Center. So some of you may know me from either one of those roles. Today I'm here to talk about OT, specifically with the AGS population. I just wanted to point out on the first slide, my email is at the bottom, so you can feel free to email me if you have any questions, concerns, or just need more information about anything. What exactly is occupational therapy? Occupational therapy focuses on maximizing an individual's independence in activities of daily living. So ADLs is something that we refer to a lot with occupational therapy. It includes dressing, playing, school, meal prep, anything that is part of what a person does in their daily activities. We look to identify problems that are in these areas and then come up with interventions. And this may include skill development, caregiver training, use of adaptive equipment, and techniques. The nice thing about OT is that they can be found in a variety of settings, inpatient, outpatient, hospital, rehab, school, mental health facilities, and the community, just to name a few. Depending on what area and what setting your therapist is in is going to sometimes affect what their goal is and their overall focus for therapy. Let's say like outpatient therapy should be very focused on parent goals and overall family goals, where school is going to be obviously based a little bit more on education. What can OT do for you? OTs work collaboratively with parents and families to improve a patient's well-being based on their specific needs. So first, we would complete an evaluation to understand the current status of the patient and hopefully be able to compare that to a previous status, or to understand better where the family hopes short-term and long-term goals can be. We should be working together to make that realistic. So breaking things down into steps, the short-term goals would be the steps to get to the long-term goals. A hands-on assessment should be completed. However, nowadays, a lot of times we do also do a lot of telehealth assessments, which can have their own benefits, like being able to see, a family routine in the home, see what things you have available in the home, and the therapist can hopefully get a good sense of how to maybe adapt things or tweak your routine a little bit to make it more successful. In the next slide, we're going to talk about common areas addressed in OT. So vision, range of motion, positioning, splints and braces are a few. Just to name a few, that list could probably go on. And we're going to talk about these more in depth. I just gave a quick little summary under each one of them. So often children need help utilizing both eyes together or will have some visual deficits. And unfortunately, this can be commonly overlooked by many therapists. An OT or a vision therapist, a vision specialist, I should say, will have the goals of understanding a patient's gaze preference, if there's color preferences, if they respond to light or darkness, and how to position them in order to be the most successful. So you can also look at the covd.org website, which is a great resource that has optometrists you can find. And then what I have pictured in this slide is something called the little room, which is used often with children with CVI. It's just, something that can be engaging for them to fixate on, to help you figure out what their favorite colors are or preferences, and then shape that vision to something more functional that hopefully can be used for communication or just overall interaction. So a thorough assessment of range of motion and recommendations would be provided based off of the deficiency seen. So whether that's going over proper passive range of motion, splinting and bracing, to maintain joint alignment and integrity, or to make the patient successful, say in like a side-lie position, to have a gravity neutral plane when reaching, just again to maximize function with play or any other task that they're trying to do. Head control is another area that we often see impacted. So therapists could help with different collars The little girl in this picture is using a Hinsinger collar, and then the other picture is of the head pod, which is kind of more of an adaptive device that would be used on a chair or wheelchair to help hold the head upright so that the child could, take in hopefully the whole environment. Dynamic truncal orthosis, I know PT also touched on this, but OT would also be looking at different ways to help stabilize the core in order to hopefully improve head control and use of both arms, say during feeding or fine motor tasks, etc. Next, we have common splints. So resting hand splint, dorsal cock-up splint, a thumb abduction splint, and a weight-bearing splint are just a few that I commonly recommend. The top blue picture, that small one, is a resting hand splint that would be used just to maintain, the hand open and muscle integrity. Sometimes it can be progressive to try to get range if it's a progressive resting hand splint. Below that, the white and the red one is a weight-bearing splint. Different types of weight-bearing splints to try to get the patient to be able to bear weight through the arm. The dorsal cock-up is the one at the bottom left that I really like because it keeps the wrist in neutral and then also allows for finger movement and grasp and for the patient to touch the items. The thumb abduction splint in the pink is a nice low profile splint so the patient could move their thumb, but it would keep it a little out while they're grasping. In the next slide, we're talking about positioning equipment. So we refer to that as durable medical equipment. We're going to go into each of these more in depth, but one of the things I like to point out is that we always recommend going through a seating clinic versus an individual therapist ordering the equipment. A seating clinic is just going to be more knowledgeable. They're typically found in a hospital setting. They can help you with appeals, denials, if the equipment breaks down. If you're going through an individual therapist, you really have to rely on their education and always being able to get in contact with them is some of the downfalls that we've come in contact with. Positioning and feeding chairs. Here we have pictured the special tomato with a tray and the Rifton, which are commonly ones that we do order and get approved through insurance. A Peapod chair is something that a couple parents have showed me and introduced me to, which I do love. It's not the most ideal for positioning, but it is more of a relaxing, comfy chair. However, in my experience, it has been a little bit more difficult to get approved through insurance, so that's something to consider and factor in. But I know that people have done like GoFundMe pages or, did collections for maybe the holidays or something like that to put that money towards a piece of equipment that might not be covered under insurance. Bath chairs is the next slide. So we have Otter, the Rifton Hygiene toileting system, and a Splashy. The Otter is a very common one that's ordered and approved. The Rifton is a newer one. The Rifton Hygiene one is nice because it can be used as a commode or as a bath chair, so it does get approved more often. The thing with this is that you do need a walk-in shower to be able to use that chair. And then the Splashy is a parent favorite. Again, depends whether or not it gets approved with insurance, but I think parents like it because it's very portable. You can have kids out in like a little kid pool playing in it, or I've seen parents take it to the beach with them. So again, there's things to factor in. Toiling systems, these can be really hard to give like a general idea, but as you can see, there's many different types. There's a basic commode, ones with steps. In the left side, we saw the one that could be a commode or a shower chair. Again, it's understanding what your child's skills level is and trying to match that with the correct item. Medical strollers versus wheelchair is something that we often talk about. So the kid cart is this top one, top with the red back. That one's really nice because it has the lateral supports, head supports, it can tilt, it's small, it can be heavy, but it does tend to be like a favorite of most families. Then you can look at powered wheelchairs, which are nice because they can be done, a patient can move them with just a switch or finger movement or head movement. And then you have things like the manual wheelchair that the child is in, trying to propel that themselves. So lots of options. So adaptions, that's probably one of our favorite things to do as an OT. I know it's mine, is to try to come up with ways that we can adapt things, whether it's through an eye gaze machine, a switch toy, for the powered wheelchairs, or here we see a patient that is in one of the kid motorized mobiles that we adapted so that it can either just be a head movement again or an arm movement that'll make the car move forward or backwards. The easy holds I like because they can keep items in the hand so the patient doesn't drop them if their grasp is weak. Liftwear is something we can look at that will help with tremoring or kind of uncoordinated movements. There's adaptive clothing lines now for children. So lots of options you can talk to your therapist about and together come up with solutions. I've seen so many creative ideas and I love seeing them and helping. How to obtain the medical equipment. Again, we recommend going through a seating clinic, which is usually in a hospital. There'll be a therapist and a vendor working together. The clinic will help with denials or if the equipment breaks. I included the number for our seating clinic at CHOP if any of you are local. An orthotist would be the next person that you would want to go to if you're looking for splints or any kind of truncal orthosis or bracing. Again, that should be in collaboration with a therapist. And then the last thing I wanted to touch on was occupational therapy involved in research with AGS. So right now we've been looking a lot at parent-reported measures such as the PVCAT. Some of you might have completed that for me, and I appreciate it. We're trying to validate some remote measures so that things can be done, over the computer or via telehealth. And then also the use of developmental measures that we can hopefully adapt and make them better for our population. We do appreciate everyone's willingness to take part in this, and without that participation, we would not be able to be successful at all. So that is the end of this slideshow for today. I appreciate all of you and thank you for the time and for having me. And any questions, I'll be available for the live session. And like I said, you can also email me at cusack@chop.edu. Thank you and have a great day.